The other question, which I think is a very controversial one, certainly in Scandinavia, there's now evidence coming that low-volume centers doing elbow arthroplasty have had a higher rate of revision and complications. So certainly, at least in Denmark, they now make all the elbow arthroplasties done in high-volume centers. Is that something that you think is going to happen in our countries, or do you think that's maybe there's a difference in practice patterns?
I think that is a subject that is so difficult to regulate that it's unlikely to happen in North America, I think. I get the impression that in the community the most common indication for an elbow arthroplasty is a distal humerus fracture. So I think the emphasis in education, if we want to, in general, decrease the rate of complications, is to train surgeons well about how to do an arthroplasty for that specific indication. And maybe the idea would be that anyone or someone with experience can do an elbow arthroplasty for that indication, and then if you have a patient with post-traumatic OA or rheumatoid, maybe those should be sent to a more specialized center. But it's very difficult to regulate.
For sure. See the time here. One of the other comments was from Peter Evans asking about the triceps tongue again. Now that you do the triceps tongue, it's a very short piece of tendon. You're not really cutting much muscle, then there's more of a muscle split, more proximally. Is that the way you're doing it?
Is that for Peter?
Well, I was going to ask you first, and then I don't know if Peter's on the line or not.
You hear, Peter?
There,
yeah, the
Peter?
tongue can actually be pretty long, like 5 to 7 centimeters up the triceps, and then...
Yes, you could. Exactly. I think you're right, Hill. You can make it quite high up, and you can do it as a V or a square. We published this recently, and I think the key is that we don't destroy the muscle. In fact, you're just taking tendon and reflecting it distally, and then you split the muscle longitudinally, so you have that nice vascular bed for the tendon to heal on.
So for Peter and Hills, when you guys do a triceps tongue, how do you protect your patients after surgery? What do you recommend for the first 6 weeks or 3 months?
Go ahead, Al.
Well, yeah, you can still work on full active and passive flexion and extension. You can use passive extension and weighted gravity extension. You just can't do resistance to extension. I think, when I used to use the Guichuan split or the Brian Morey, I think one of the issues is whether the tendon heals to bone as predictably as tendon heals back to the tendon. So I've gone through all the scenarios over the years and gone back to this tongue of triceps as Peter's talked about. And I think that there's pretty good tendon healing that way, but yes, you do have to protect them afterwards.
So Graham, then why are you hesitant about trying the triceps tongue? Because you're really trying to use a triceps on approach in your primary. So what's your concern about the triceps tongue?
Well, I guess I'm waiting for the gurus here to convince me to change. I mean, I spent so many years trying to get away from taking off the triceps, and to be honest with you, it's working for us wonderfully. But it does strip the humerus, as I showed you in the video, for those of you that were able to see it, and that's really the concern. I mean, I think particularly if you're going to do an unlinked arthroplasty, then I have more concerns about the lateral parallecronon approach than I would with a triceps tongue. But of course, most people aren't doing unlinked arthroplasties, so maybe it's not something that is so important. I do think it's important when you're starting out with total elbow replacements to take off the triceps. So I would recommend all those people in the audience that are doing their first, second, or third elbow replacement, not for a fracture, but for arthritis, to get the triceps out of the way, or you're going to get yourself in big trouble. So in those cases, I think a triceps tongue makes sense. Maybe after some more experience, then you want to move to a triceps on technique, certainly for particular patients, as I tried to outline.
Yeah, and also, if you do use the paratricipital, particularly for fracture, which is an easy scenario for that, it's easiest to get the alignment down the ulna going from the lateral side of the triceps. So you're less likely to perforate, I think. And studies have shown, as already mentioned, more than 10 degrees of malrotation of the ulnar component is a problem.
Mm-hmm. Let's do one case here. This is a patient that has a painful total elbow after a fracture. She's 86 years old. She has a past history of a left humeral fracture, treated with open reduction internal fixation. Unfortunately, that didn't work out, and the fixation failed, and the elbow dislocated. In 1998, she had a total elbow arthroplasty, and now she presents with a 2-week history of severe pain, difficulty using her arm. She denies any trauma, and she has no neurologic abnormalities on history or physical examination. So here's her original fixation with dislocation of the elbow. That, in my experience, usually means someone cut the collateral ligaments when they put the plates on, which, for those of you using medial and lateral plates, be cautious about that. But this is the patient presenting now with what looks like a loose ulnar component and a well-fixed humeral component. So maybe we'll just go down the line here and get people's feedback here. So Joaquim, what would you be thinking here is the issue, and what would you do?
So this patient, I would bet that had a pre-coated ulnar component, because I see a lot of distal osteolysis. So
yeah.
The sequence of events I think happened is that the component loosened up, and that combined with the pre-coating led to osteolysis that then led to a fracture. The humeral component looks reasonably well fixed, so I would be thinking of taking into account the age of the patient, leaving the humeral component and revising the ulnar component. And as Dr. Hastings mentioned, by the time you get there, bone is avascular and very poor, so typically the bone defect is actually worse than you anticipate on the X-ray. So I would be ready to either augment the bone with strut grafts or consider an APC. One of the issues I've had doing APCs in the past is that then you have an issue with triceps function as well, because you are hoping to have the patient's triceps, if it's there, to heal to the allograft, and that doesn't work very well. So my preference in these patients is to get a proximal ulna with a triceps allograft, and then use the allograft triceps sutured to the triceps of the patient, so that in the same operation you basically do both.
Great. Hill, what would your approach to this be?
Yeah, so I tend to share Dr. Sanchez's idea that this is probably just a pre-coating that led to osteolysis and then loosening. So I would still be fearful of infection. So I would go through the same routine of workup with aspirates and then special studies on the aspirate, C-reactive protein. I'd get multiple biopsies, at least 3 to 5, ideally 5, for study at the time of revision. And I probably would go in this lady for a single stage revision. She's 88 years old. I have not been very successful at getting the olecranon to be replaced or the triceps to function after something like this. So I've tried grafts, but the implant takes up so much of the space, as does cement, that it's very difficult to get any kind of olecranon graft to really heal successfully. So what I've employed usually is taking a mersaline tape, weaving it up the triceps, and then actually bringing it around the front or anterior side of the ulna, just distal to coronoid. You can't really attach much, of the triceps into the proximal ulna because there's nothing to fix it to. So I use the mersaline tape that simply brings the triceps, and then it wraps around. The tape wraps around the front of the ulna and then back up the triceps posteriorly. So I'm a bit pessimistic about trying to get the triceps to work. I probably wouldn't pay the effort in making that happen.
Peter, any other experience or comments about the 4 triceps here?
Well, I think the only other thing I've done is I've actually weaved semitendinosus through, and when I'm using my strut grafts, typically I would probably put a longer stem with some strut augmentation here. I've actually used the cables. I tend to use the Kinamed cables, and I've weaved my semitendinosus graft to the cables and use that as a way to hold it to the proximal ulna.
I think we've got some post-op pictures here, and so there was various options are presented to the patient, most of which we've discussed, and see the significant bone loss at the time of revision. This is Scott Simon's case. And you can see the strut grafts he used with cable grafts to reconstruct the substance of the ulna. And here the patient is at 3 years with, as I understand it, a reasonably functioning elbow.
Looks like there's a lecrin on there.
There does appear to be some lecrin on there, so obviously I don't know if that's something you put there or not. But usually my experience is if I put it there, it disappears, so I haven't had much luck with that. I must say I'm pretty pessimistic about getting any tricep function in this kind of patient. It really just hasn't been successful. I actually don't put a lot of effort into it because I think, you know, if you put a lot of dead tissue right under the skin there, sometimes I think it's worse by doing that, but that's just my thought about it. Okay, is there any, there was one final question in the chat, and we're going to finishing up here. One of the question here was, is it better to use a linked or unlinked total elbow in distal humeral fractures? So, Peter, what do you do for distal humeral fracture? Are you using a linked or unlinked arthroplasty?
I'm using a linked right now.
No?
I also use the link. Pretty much everything in the literature up till now has shown better survivorship with linked than unlinked implants, but that's still what I do.
Joaquin?
Yeah, the same thing. For most patients that I consider an elbow arthroplasty for a fracture, I will reset the condyles. So by definition, there is no origin for the collateral. So I think in that situation, you're almost forced to consider a linked prosthesis. If you did unlinked, you will have to also fix the column so that you will have some collateral stability. How about you, Graham? What do you do?
Yeah, for sure. I mean, I've done a couple of unlinked arthroplasties for fractures, but these are very young people that I really don't want to do a total elbow in. But in general, those are patients, you know, north of the border. We still use the hemi, and that's what we're using for that kind of population. But remember that when you use a hemi, for those of people in countries where you have access to it, doing a hemi is like doing an unlinked elbow arthroplasty. So you need to get the collateral ligaments to heal, and usually since there's epicondylar or condylar fractures, you need to fix those fractures as part of putting in a hemi arthroplasty. You can't just put the hemi in and expect the elbow to work. So the data coming out on the newer implants is kind of interesting and encouraging, but I still think they require a lot more technical expertise than putting in a linked arthroplasty. And I really don't know, you know, how they're going to last in terms of durability. So I really don't think it's for the average old patient with a distal humeral fracture. It's for the young, active patient with unreconstructable distal humeral fracture or non-humeral. Well, I think we're going to have to close there. I really thank all of our presenters tonight for coming. Unfortunately, Scott Simon had to leave early, but he certainly sends his best regards, and I thank all of you for attending. I hope you found it valuable, and I look forward to any feedback that people might give us for the future webinars here at VMedi.